So to give you an overview, this is going to be the next 4 or 5 sessions. So in the first one, we are going to take up how do we work up undifferentiated pediatric anemias in the emergency department. So if a child comes who has got some degree of pallor or anemia, or you think like he looks like that he might be having some problem with his hemoglobin, hematocrit, things like that, and at that point in time they are undifferentiated. We don't know what is the cause of that, whether that's an iron deficiency, whether that's hemolytic anemia, whether that's like any sort of B12 folate deficiency, whether there is some like infiltration of the bone marrow. We don't know. So how do we work up? So the focus is not to make a pinpoint diagnosis in that one session. The focus is to narrow down on a group of disorders, and that also helps because even you narrow it down to the group of disorders, maybe then you go back into the history or physical examination, and you might even pinpoint the diagnosis. So it makes your job very, very easy. So so today we are talking about undifferentiated pediatric anemia. So let me start with a case, okay, and that would you just like think about. So this is a 10-month-old girl who has been referred by the general practitioner. Why? Because on examination for something, he put his stethoscope and he heard a murmur. So he thought that there's a systolic murmur going on. Otherwise, the child is well and asymptomatic. So the child hasn't got any symptoms. Now, on examination, this child has been sent with a letter that he thinks there's a murmur something and it needs cardiac evaluation, or usually, sometimes they write about like so many things which they think do this and do that. Anyhow, so you do your examination. The child looks significantly pallid. So you agree that there is some degree of pallor, and the child seems to be slightly small. You think that maybe the child is slightly small as compared to a normal 10 months old. And obviously, you're now scratching your head because the child is significantly pale. You start with a simple blood gas to give you an idea, screening the hemoglobin. And you find that the child has got reduced hemoglobin and reduced hematocrit. So both these parameters are down. So you think, okay, well, fine. Now this pallor is because of this some degree of anemia, because the hemoglobin is down, the hematocrit is down. So this needs a proper full blood count, okay? And obviously, as a part of your workup to refer this child onward to the pediatricians, you will have to do a basic workup. So fine, you do the basic workup and you take the purple bottle for FPC, and within an hour you get these results which I have shown on the left side. So if you look, the RBC count is 2.1 into 10 to the power 12 per liter. The hemoglobin is 65 gram per or 6.5 gram per deciliter. Hematocrit is down to 19%. MCV is 99. MCH is 31 picogram, 34% MCHC. Absolute retic count is 8,000, and the corrected retic count in percentage is 0.63. Platelet count is 285. White blood cell count is this, and our red cell distribution width is this. Pause for a moment. Look at these parameters. What do you think? Not expecting a diagnosis, just pick up abnormal. What do you think are the abnormal values here?
So the HB shows that it's not necessarily acute. So this is a chronic, long-standing anemia. The child's not actively bleeding now, although hematocrit being low. It is MCV is high. Interesting. Now you don't give us the reference for MCH.
Okay, fine. Let me tell you, it is from 27 to 35.
Okay, so MCH is normal.
Yes, same goes for MCHC. Let's say that is from 29 to 35.
Okay, so interestingly, it's macroscopic, but it's not necessarily that macroscopic. It's just over. Macroscopic anemia. Reticulocyte is low. Okay, so the reticulocyte is low. So this child obviously trying to correct, but there's not enough reticulocytes to correct this. So we need to look at the source, bone marrow. Yeah, so I'll be going that way.
Fine. And Dr. Gupta, what do you say? Dr. Gupta?
Yeah, now Samuel has picked up the general rhythm,
Mm-hmm.
which appears to be in the right direction.
Mm-hmm.
Only one parameter is involved, which is the RBC in hematologic. White white cells and platelets seem to be okay.
Hmm.
It is macrocytic
Mm-hmm.
to some extent, with reticulocyte low. So one should look towards the bone marrow. Aplastic is something to do with you know the something in that direction. Black farm diamond syndrome, and something towards RBC production, um, and uh, um, possibly towards underproduction, but they could whether there is hemolysis, we don't know. I don't think so. So that would be the general direction. Yes.
Okay, Dr. Ocean?
I think we should. Oh, Ocean. No problem, Ocean.
Yeah, I think it's you have started in that direction, Dr. S1. I think it's a problem of production, but the confounding factor there is the MCV that is high. So I will go for a problem of production.
Yes. Also, do you want to say something else as well?
Oh yes, I just wanted to say, let's not forget about the spleen. You're not saying anything
Okay,
clearly about
so
the
fine.
spleen.
Okay, so on examination, let me tell you on examination, because on examination everything was fine except this for pallor. So there's no hepatosplenomegaly, there are no bruises. Except I told you there is a generalized pallor, and there is no abdominal distension. So there is no hepatosplenomegaly in this case.
Thank you.
Yeah. So just to give you an idea, fine. So all of you are very, very correct that at least you have picked up. I was not expecting a diagnosis, but I'm trying to bring you towards that side. Okay. So we'll come to this case and some other cases at the end of this session. But you've very rightly picked up that the hemopoietic, factor relating to, RBCs, they seem to be affected. I mean, if you look at this, why? Because your blood has got other lines as well. You've got the platelets, you've got the white blood cell count, and it seems like this picture is showing that only the RBC line is affected. The other lines like the platelets and the white blood cells are not affected. So there is something, whatever it is related to the red bloods. Okay, RBC. So something is affecting the RBC line as well. It's not like a sort of a cross cutting in the sense that it is like, affecting all the cell lines. So something is only affecting the RBCs. So fair enough. We'll come to this case later on. Now, moving on, I want you to understand in this session that how would the mean corpuscular volume, like you talked about, that MCV look to be a bit on the higher side, okay? Now you would also say at the same time, I mean, you all are experienced clinicians. Most of the times when we see anemias on the full blood count, you'll see majority of them are microcytic, or are normocytic or microcytic. Macrocytic very rarely comes, in like into the limelight as far as a clinical practice is concerned. And usually, I would be more worried if I look the macrocytic anemias rather than the microcytic and what you call the normocytic anemia, and there is a good reason for that. So we need to understand what is the role of this average volume of the RBC, and another factor which we never pay attention to, and that is the red cell distribution width. How does these two combine to help us in further narrowing down the differential diagnosis? So MCV itself and red cell distribution width, we will be using these two parameters to pinpoint the diagnosis. Okay, and we will also talk about what are the common causes of pediatric anemia based on the combination of MCV and red cell distribution values. Okay, now moving on, there are many definitions of anemia. Okay, when we say so, anemia basically is the reduced oxygen carrying capacity of the blood. Now, it's not saying that it is a reduction in hemoglobin or RBC. It says basically the problem is that there is reduction in the oxygen carrying capacity because of, and there could be various reasons for that, because either there is a decrease in the RBC mass, like the RBC numbers are decreased, or either there is a decrease in hemoglobin, within these RBCs, or the hemoglobin may be abnormal in structure or function. The hemoglobin might be normal in quantity but still might not be able to function properly. So it would lead to reduced oxygen carrying capacity, and that reduced oxygen carrying capacity would actually translate into what we call as anemia. So traditionally, the way we look at anemia is like we look at the hemoglobin and hematocrit values, and from there we say, oh, this child is anemic because the hemoglobin is falling or the hematocrit is down. But if you look at the full blood count report, it not only contains hemoglobin and hematocrit, it contains so many values, other values, which help us in differentially diagnosing the anemia. So anemia by definition is reduced oxygen carrying capacity, either because of qualitative or quantitative deficiency of RBCs and hemoglobin. Now, moving to these parameters, MCV and red cell distribution width. So MCV is the average size of the RBC. RBC is a biconcave disc. It's a biconcave disc. So the average size of that microscopic structure is your mean corpuscular volume. So it is actually calculated in very small, femtoliters. Liter is a big one. So femtoliters is the unit which is used to calculate, sort of express the size of an RBC. And again, it depends from book to book. Some books say 80 to 100 is the normal average size of an human RBC. Some say 75 to 95. So every lab can have a different value, and it depends. So you can either take the 75 to 95 depending on whatever reference range is used by the lab, or 80 to 100. Again, as I said, different books have got different values. So remember, your blood vessels are just like a river, and the RBCs floating in them is just like a boat. So a microcytic anemia would be equivalent of a very small boat. So I think I'm covering this picture. If you see like a big Amazon river, and in that a small dinghy boat is flowing, or many dinghies are flowing, that would be equivalent of a microcytic anemia, that there is a big river and there are small boats floating in that. Microcytic, small boats. If it is a normal average size boat, like flowing through that river, like as you can see in this middle picture over here, so that would be your normocyte. So it means a normal size boat, flowing in that river, which is actually blood. And macrocytic means you've got a giant cruise liner which is actually passing through that river. So big cells, big like a big ship. So that is this analogy. Okay, so simply keep that thing in mind. So this is a sort of an depiction of the red blood cells based on their size. Microcytic means small red blood cells, normocytic means like the normal average size, and the macro means big RBCs there whose like size is big, volume is big. Now this is for MCV. What about red cell distribution width? So red cell distribution width actually shows you how much variation is there in the size of the RBCs, because if let's say the river is blood, so either there are all small boats, flowing into all like a sort of a normal size boat, or big size, or there may be a combination of like some boats are small, some are average size, some are big size. The more the variation, the more would be the red cell distribution width. So red cell distribution width actually is telling you how much is the variation in the size. So high RDW means that there are small RBCs, there are medium size RBCs, and there are big size RBCs. There are a lot of variation in the size. So just look at children of one size. That simply means even that those children may be small in size, but still there is no variation. So if all the cells are microcytic, you will be getting microcytic anemia, but the red cell distribution width would be normal. Why? Because all these cells are of small size. And red cell distribution with high means that you have got cells of different sizes. Some of them are small, some of them are average size, some of them are big. That is also known as anisocytosis or anisocytosis, as some people call it. Because anisocytosis means simply variation, a lot of variation in the shape of the red blood cells, and the higher it is, higher is the red cell distribution width. So red cell distribution width is usually around like 11.5 to 14.5%. Again, different labs uses different. I think our lab uses 8.5 to 14, something like that. But nevertheless, most of the labs around the world use the reference range of 11.5 to 14.5%. So red cell distribution width actually showing you how much variation, and this is a very helpful parameter because this, when you combine with MCV, can narrow down your diagnosis of anemia. So let's talk about based on this. So you can have a microcytic anemia, you can have a normocytic anemia, and you can have a macrocytic anemia depending on your MCV, whether it is less than 75, whether it's between 75 and 95 or 80 or 100, or if it is greater than 95 or 100, whatever values you are using. So either it will be microcytic, normocytic, or macrocytic. Then all these anemias would be having either a normal red cell distribution width or a increase. So if you got three categories, microcytic, normocytic, macrocytic, and each one has got two further categories where the red cell distribution width is normal or increased, normal or increased, normal or increased. So you have got now what? Six groups. Most of the microcytic anemias in general means there is problem with production, because if your RBCs or hemoglobin is low, there are two problems. Either there's problem with the production, either there's problem with consumption, or sometimes there could be a combination of both. Production is also affected and consumption is also affected. So microcytic mostly tells you that there is a production problem. The factory is not working properly. There's some problem. Either the raw material is not there, workers are on strike, or machinery is old, whatever. Or the machinery for some reason is not getting proper power supply, things like that. But there is problem with the production. Normocytic can tell you both. It might be because of problem with the production or problem with consumption. So if you've got consumption problem, like where the RBCs or the hemoglobin is being destroyed, broken down, you mostly would be seeing like normocytic anemia. So again, it can go either way, production or macrocytic. Again, most of the times they tell you that the problem is with the production. So microcytic and macrocytic are mostly production problems, and normocytic can be production as well as consumption problems. So we've got now 6 categories, and we'll move one by one, and then I will show you a sort of an algorithmic approach to that as well. Let's talk microcytic anemia. Most of the times when you look at the full blood count report of any child which you have ordered for any reason, you will see that if they've got anemia, most of the time if there is some problem, it would be microcytic. So microcytic means that these cells are mostly smaller in size. They're small, less than 75 femtoliters. Now again, I told you that if you've got microcytic anemia, again, you look at the red cell distribution width. So if the red cell distribution width is normal or is it increased? Two possibilities. So if you've got microcytic anemia and you have got a normal red cell distribution width, so you are probably dealing with what we call as a thalassemia minor or a thalassemia trait. Remember, because most of the time macrocytic anemias are caused by iron deficiency anemia. So, and again, iron deficiency anemia is one of the most common cause of anemia in children, but not especially in the ER. It's not the common cause of presentation in the ER, but like on a journal, it's a more so we probably think that if you are dealing with that, so with anemias, red cell distribution, iron deficiency, the red cell distribution width is usually high. But if it is normal, hemoglobin is low, microcytes, you're possibly dealing with what we call as thalassemia minor or trait. This requires further confirmation with HB electrophoresis. I will come to that if you find further tests you need to do or order on that part. So with normal red cell distribution width in a microcytic anemia, diagnosis very straightforward. You are possibly dealing with a thalassemia trait, minor thalassemia as we call it. Especially if they are coming from South Asia or like they are of Mediterranean origin, Turkish, Greeks, Lebanese, Egyptians, like all around the Mediterranean coast, okay? If with a microcytic anemia, you have got an increased red cell distribution width, it's more than 14.5, 15, 16%, then there are a few further possibilities, okay? There is like group of, so either you are dealing with iron deficiency anemia, you might be dealing with sideroblastic anemia, or you might be dealing with anemia of chronic disease, especially in the late stage. It's been going on for a long time. Now, how would you know? Because now we are dealing with three possibilities. Either it's iron deficiency, it's what you call sideroblastic anemia, in which there are ring sideroblasts, or anemia of chronic disease. Now, sideroblastic anemia is quite rare. I mean, probably I think in my life I've just seen one case. Iron deficiency and chronic disease are much common as compared to that. So how we further go with this thing? So we've got microcytic anemia where the red cell distribution would increase. This definitely requires iron studies. So what are iron studies? Your iron studies are three things. Serum ferritin, 1. Number 2, serum iron. And number 3, total iron binding capacity. In that, serum ferritin is one of the most sensitive indicators of early iron deficiency. Remember, early iron deficiency. So in early iron deficiency, what would happen? The first thing to get a hit would be serum ferritin. Now serum ferritin goes down, hemoglobin would still be normal. So if you see a child whose hemoglobin is normal, ferritin is down, early anemia. Last week, I saw a girl who was suffering repeated collapses and other things, was using fludrocortisone TTS for 6-7 months, still getting attacks, drop attacks. So, and again, had been investigated a long time. So they said all the investigations were normal. So I just went through the previous records and I found that in 3 or 4 tests, she had serum B12, folic acid, iron studies, everything. Her serum ferritin was constantly on the lower side. It was down. Hemoglobin was still normal. Another thing was folic acid was also low. But her, so I started her on, I said, okay, well, fine, you've got iron deficiency without anemia because your ferritin is down, you've got early stages. So at least let's start correcting these things and see if that makes any difference, because she's already on other medications. So I said, okay, well, fine, let me start you on folic acid and let me start you on this thing as well, because this is what, and that was not diagnosed. Like, over 3 or 4 different types of blood results, nobody told them that this deficiency was existing. Probably they thought because the hemoglobin is normal, so there's no need. So the thing is that this is the most sensitive indicator of iron deficiency. So if your ferritin is down with this, you are definitely dealing with iron deficiency anemia. Your ferritin would be low. If your ferritin is on the rise, it's high with a microcytic anemia, then you are probably dealing with anemia of chronic disease, because ferritin is also an acute phase reactant. It's an acute phase reactant. So it would be increased. Serum iron. Okay, another interesting question is, what if somebody has got iron deficiency anemia and also has got anemia of chronic disease? How would we differentiate that? Because if anemia of chronic disease, the ferritin should be high, because ferritin is an what you call an acute phase reactant as well, and there's deficiency of iron as well. So how would we differentiate between the two? Any idea? Okay, let me tell you. So the total iron binding capacity is the other parameter to look at. So if the total iron binding capacity is increased, the capacity is increased with a decreased ferritin, you are dealing with iron deficiency. If the total iron binding capacity is decreased with an increased ferritin, then you are probably dealing with anemia of chronic disease. So normal microcytic anemia, normal red cell distribution width, think of thalassemia's traits. Okay, if increased, either you're dealing with iron deficiency, anemia of chronic disease, rarely lead poisoning or sideroblastic, very rare these days. I mean, for practical reasons, forget about that. Like, it's either between anemia of chronic disease and iron deficiency, and then this iron studies can further help in that. Okay, so this was how do we use the red cell distribution with MCV to work up microcytic anemias. Now coming to normocytic anemias. Again, normocytic anemias are more tricky because they can be either caused by problem in the production or problem with the consumption as well. So first, if you got normocytic anemia, again you look at the normal red cell, the red cell distribution width, either it is increased or decreased. So if it is normal, let's say, so you have got a child who's got pallor, hemoglobin is low, but MCV is normal and red cell distribution is also normal. Okay, just the hemoglobin is on down. Okay, and you will come out, this is also quite a common condition where the hemoglobin is slightly showing the blue boxes, but down you look red cell distribution with normal, and the MCV is also normal. This can happen. What's common is acute blood loss, especially in trauma cases. Okay, somebody who has lost blood because it's been bleeding and wound or something, have blood for some time, so they can have a low hemoglobin, but their MCV and red cell distribution width would be normal. So acute blood loss because of any reason, and we are talking about acute blood loss, I'm not talking about chronic blood loss from, let's say, GI cancers or something going on in the, let's say, celiac disease or inflammatory bowel disease. I'm talking about acute blood loss, so like severe menorrhagia or wounds, things like that. So one is acute blood loss. In the early phase of anemia of chronic disease, so we talked about that anemia of chronic disease actually gives you what? Microcytic anemia with a high transferrin levels. But in early stages, like every chronic thing would at some point start. So in that case, you cannot call it chronic because now it's the beginning of a chronic thing. So in the early stages of anemia of chronic disease, the anemia would be normocytic and normochromic with normal red cell distribution. So there would be just like, hemoglobin would be down, but MCV over a period of time, then what would happen? These normocytes would convert into microcytes, and the red cell distribution would start like, going broad. So in the early phases of anemia of chronic disease, you will see this picture. Just hemoglobin down, everything is fine. Over a period of time, then it would shift to microcytic. Anemia of renal disease. Somebody who's got chronic kidney disease, they also have got normocytic anemias again to begin with. Okay, in like, they would be having normocytic and normochromic anemias with a normal red cell distribution. Maybe over a couple of years, then they would eventually might develop other forms as well, but to begin with, most of the times they've got normocytic and normochromic anemia with a normal red cell distribution because of the deficiency of erythropoietin. If in normocytic anemia, another one thing that we need to order, which is not part of your normal full blood count report, but can be requested, is the Retic count. So I would say whenever you see a normocytic anemia, irrespective of red cell distribution width, order a Retic count. This is very, very important. So step number 2 after looking at this would be go for the Retic count. The Retic counts, again, there could be Retic count is an absolute Retic count, a corrected Retic count. So both have to be calculated, and usually when they do the Retic count, they tell you like which is the absolute Retic count and which is the corrected Retic count as well, like because the machine does all the calculations for you. Why we are looking at the Retic count? Because this is normocytic anemia, so we need to see whether this is a problem of consumption or destruction. So if there is a problem of consumption, because it's being consumed, so to compensate for that, Retic count would go up. And mostly consumption problems are your hemolytic anemias. So hemolytic anemias, they do present with anemia. You can say, well, another clinical thing that helps in that is that most of them would be having visible jaundice. Not only pallor, but jaundice. So there's some hemolysis going on. That further, sort of a, actually gives you this idea that some form of hemolytic process is going on. You may not be able to pinpoint what sort of hemolytic process is going on, but at least you can tell that some form of hemolysis is going on, because why? There is some degree of jaundice as well. So Retic count is very, very important, because if the Retic count is high, it means there's a problem with consumption. So if the Retic count is high, step number 3, if this is high, this is step number 2. Step number 3 would be to request Kums test. Kums test. This is commonly known as direct anti-globulin test, DAT, DAT, direct anti-globulin test, Kums test. Because Retic count high means you are dealing with hemolysis in a normocytic anemia. Now, the next question is whether this hemolysis is immune mediated or non-immune mediated. Whether it's immune mediated or non-immune. So, Kums test positive means it's immune mediated. So, something related to the immune system is causing destruction. So, the RBCs have been sensitized. It can occur in like SLE, it can occur in different types of multi-system connective tissue disorders. Okay, they can cause or it can simply occur what we call autoimmune hemolytic anemias. So autoimmune hemolytic anemias, in which there is some form of antigens attached to the RBC, which is actually attracting the antibodies to come and destroy the RBCs. So that is the case, because that also helps in management. In all autoimmune hemolytic anemias, you will be probably thinking of steroids from management point of view. If the Kums test is negative, you are dealing with a hemolytic process, but non-immune mediated. It's not mediated by immune. It's something else going on again, and then there could be variety of reasons for that. So if you've got Kums positive, you are dealing with autoimmune hemolytic anemia. If you have got Kums negative, there could be various possibilities. You might be dealing with G6PD deficient if they are coming from this, what you call again, from this Eastern Mediterranean coast. It could be because of sickle cell disease. It could be because of some other forms of hemolytic anemias. It can be because of hereditary spherocytosis. It can be because of pyruvate kinase deficiency. So there are various reasons, enzymatic, or sometimes in certain forms of mechanical hemolytic anemias like hemolytic uremic syndrome or thrombocytopenia, thrombotic thrombocytopenia purpura. In that, there is sort of a mechanical destruction of RBCs. So there is a hemolytic process, not immune mediated, mechanical mediated. So in that case, Kums test would be negative, your Retic count would be high, your red cell distribution width would be normal. If you are dealing with a normocytic anemia with an increased red cell distribution width, again, this can occur in early iron deficiency anemia, because in that case you will be getting a normal mean corpuscular volume and increased red cell distribution before it progresses, and over a period of time iron is not being stored in the body. So from a normocyte, eventually they will go into small size microcyte. So in the initial stages of both anemia of chronic disease and any iron deficiency anemia, you will be getting normocytic anemia. The only one thing that differentiates between the two is that in the early phases of anemia of chronic disease, what happened, you will be getting the red cell distribution width would be normal, while even in early iron deficiency anemia, the red cell distribution width would be high. You can also get it in early phases of B12 and folic acid deficiency. We normally say that they present with macrocytic anemias, but in early stages of B12 and folic acid, you can still have normocytic anemia with an increased red cell distribution. Later on, they would go macrocytic, and not only macrocytic, that would turn into megaloblastic, like big cells, lumpy cells. Or it can occur in aplastic anemia, where there is bone marrow suppression, aplastic anemia. That can occur because of drugs or various reasons, radiation, things like that. So this is how we use the MCV and red cell distribution in case of normocytic anemias. So again, we are looking if it is normocytic with the normal RDW or increased RDW. And now coming to this what we call as macrocytic anemias. Again, macrocytic anemias mean you have got big cells, MCV is greater than 95 or 100. Again, you have to look at the normal red cell distribution, whether it is normal or whether it is increased. Now, macrocytic anemias are more important because it means more sinister, or like, big range of causes, okay, that can cause that. So either, if you get macrocytic with a normal red cell distribution, you're either dealing with, number one, either you're dealing with liver or thyroid problems. So chronic liver disease, chronic hepatitis, chronic autoimmune or chronic viral hepatitis, whatever. Hypothyroidism because of various reasons, whether it's iodine deficiency or whether it's like autoimmune hypothyroidism or Hashimoto thyroid, whatever. So you can get macrocytic anemia with a normal red cell distribution width, or slightly, even if the red cell distribution width is raised, it's very slight, because in B12 and the other form like folic acid, there will be very high red cell distribution, like probably you will be looking at around 18, 19, 20 or even more than that. The red cell distribution values are even more than that. Or the third thing is where you have got certain syndromes like Fanconi anemia or Black-Van Diamond syndrome. These are genetic conditions which causes macrocytic anemia in early life. They are related. Fanconi anemia and Black-Van Diamond syndrome. The difference between that is in Black-Van Diamond syndrome, only red blood cells are affected. In Fanconi anemia, not only red blood cells, but the other cell lines are also affected. Like it causes pancytopenia. They both can have short stature. They can have, like, thumb deformities, triphalangeal thumbs. They can have congenital heart problems. They can have congenital genitourinary malformations. They can have skeletal malformations. So it's a genetic condition basically caused by defective ribosomes, which cause like problems with translation of messenger RNA into protein formation. So normal red cell distribution with macrocytic anemia, liver disease, thyroid disease, or these syndromes. But if with the macrocytic anemia you are getting increased red cell distribution width, okay, it's very important that in all these things you ask or request for a slide to be prepared. So the difference between these are automatic. As I told you, there is a Coulter machine that does this calculation. But when something shows up, what the lab guys, they do, they prepare a slide and they give it to the hematologist, who actually puts it under the microscope and then examines with his eyes, okay, looks at the shape of the RBCs, things like that, and then they give you the report whether these cells are microcytic, whether there's how much is the anicytosis, are there any helmet cells, bitten cells, what you call these bite cells, things like that, okay. So they look at the picture. So with increased red cell distribution, it's very important that they examine the smear as well, because if the red cell distribution width is high with a macrocytic anemia and the cells are showing very large, sort of cells, megaloblast, you are dealing with either folic acid or vitamin B12 deficiency. So folic acid and vitamin B12 deficiency would lead to very big RBCs. So much that we call them megaloblasts, look like blast cells, look like abnormal cells. Or it might be because of more serious or sinister reason that is known as myelodysplasia, where there is infiltration of the bone marrow with certain type of abnormal cells. They can arise from anywhere. So you might be getting hepatosplenomegaly with that, and not only the RBCs but the whole, the white blood cells and the megakaryocytes, the platelets, everything would be affected. So myelodysplasia is basically a dysplastic bone marrow because of the infiltration of abnormal cells coming from anywhere, usually associated with hepatosplenomegaly, big liver, big spleen, and for that you need to confirm it with a bone marrow biopsy. So bone marrow, whenever you see megaloblasts or macrocytic anemia and with a high red cell distribution, next step would be to do a bone marrow biopsy as well. But if it is with the normal red cell distribution, you need to check for liver and hypothyroidism. So you need to do liver function test, you need to do thyroid function test, and you may need to order, maybe you would go for an ultrasound of the liver as well. And if that is normal, then you would start thinking of Fanconi anemia or Black-Van Diamond syndrome, and maybe then you consider bone marrow biopsy or other enzymatic tests to see if that's the case or not. So this is how you use red cell distribution and MCV values to further narrow down the diagnosis. So the same thing that we just discussed, I will summarize it in this slide. Let me see this slide, okay, over here. I think probably I am in front of one of the slides. If I just give me a moment, so if I can move myself to just oops. Nope. What did I do? Sorry, I can't. For some reason, okay, I will explain this way. Okay, so if you look here, so you have to do a workup for anemia. Okay, hemoglobin is low, so you look at the MCV value. So if MCV is less than 75, you look at the red cell distribution width. If it is normal, okay, you will be checking the RBC count, because I tell you the most of the time you are dealing with the what you call thalassemia traits. Okay, so remember in thalassemia traits, usually what happens is that the RBC count would be slightly on the higher side. If the red cell distribution width is high, you have to do iron studies, or if you can't do iron studies, at least minimum is to do check ferritin level, because based on that, if the ferritin is low, you actually diagnose iron deficiency anemia, or if it is high, then you will be thinking of anemia, chronic disease, sideroblastic anemia, lead poisoning, etc., etc. If it is between 75 and 95, again you look at the red cell distribution width. If is normal, you would do Retic count, and again based on the Retic count, whether it's normal or high, you would further do Kums test. If Kums test positive, hemolytic anemias; if negative, then non-immune hemolytic anemias. If the Retic count is normal, you're probably dealing with either hemorrhage, acute blood loss, renal disease, or maybe anemia of chronic disease in early stages. If it is high, you would be thinking of early iron deficiency, B12, folic acid deficiency, all in the early stages. Okay, and we just discussed this macrocytic anemia as well. So if you just look at this diagram and you just follow where it leads to, you would probably be narrowing down your diagnosis to that particular category. So fine. So as I told you, that a systemic approach to pediatric anemias involve that you at least look at the mean corpuscular volume and red cell distribution width. Okay, so this would help you narrow down the differential diagnosis, and I told you that you can then order further other tests. Like for example, if you are dealing with microcytic anemias, you can add, okay, do iron studies, do HB electrophoresis. If you are dealing with normocytic anemias, ask for Retic count, ask for Kums test. If you are dealing with macrocytic anemias, do thyroid function test, do liver function test, okay, and ask for what you call a smear as well. Though in smear they do most of the times, after some time you will see that in the bottom of the full blood count report there is a section for smear report as well. If it is available, you can go through that and it will give you what is the morphology of the RBCs and other cells that has been examined by the hematologist. So coming back to this case, now what do you think, going back through this, what do you think is, now we have discussed how do we work up based on mean corpuscular volume and red cell distribution width. So what other test would you like to do in this particular case, looking at the values?
You definitely have to do a smear, Kazmi.
Yes. So number one, if you look at the parameters, so the RBCs are affected.
Yeah.
Hemoglobin is affected.
MCV is high.
MCV is high. So we are dealing with macrocytic. So in macrocytic, again, the next step would be to look at the Retic count. So Retic count is what? No, sorry, not the Retic count. Retic count, I'll come to the later on. The red cell distribution width, sorry. RDW.
It's high. Is that 16.5?
Yeah, 16.5. Slightly high, yeah.
Yeah, so it's high, yeah. Normocytic anemia, high red cell distribution.
Yeah, so what could be the, as I said, like what could be the differentials in this particular case?
Oh, differentials. You've just shown us.
Yeah, I mean,
If the macrocytic anemia and with high RWD, it can be like diamond blackfan anemia or Fanconi anemia.
good. So let's say you are working up, if you go through the algorithm, so you see that, okay, the red cell, it's macrocytic anemia, and the red cell distribution width is like borderline increase, not very high increase. So you say, okay, well, fine. Should I take it as a normal red cell distribution width or should I take it as a abnormal? Okay, you can't make any decisions. Okay, you say, okay, well, fine. Let's work this up. Okay, so for let's say if you take it as a normal red cell distribution width, so you do is LFTs, okay, to see, because I told you liver function, liver disease or thyroid function because of a thyroid problem. The child hasn't got any history and they come out to be normal. Okay, so both LFTs and TFTs are normal. So that is ruled out that there is any sort of a chronic liver or you also think could be B12 or folic acid deficiency, but this is a 10 months old child. You look at the history is absolutely fine. He's not like sort of, where he was started on weaning diet at a normal, at 6 months of age. There's nothing in the dietary C that can point towards like a folic acid, but you still do the values. Let's say the B12 and folic acid levels are also normal. And if you look here with that additional parameter, look at the absolute and corrected Retic count. It is on the lower side. There is some problem with the red blood cell formation, while the WBCs and platelets are not affected. So let me tell you.
What about the renal functions?
Renal functions were also normal.
Because I was thinking of erythropoietin. So bone marrow.
Okay.
Production issue.
Yeah, so bone marrow is done, and bone marrow shows pure red cell aplasia.
Black Fun Diamond.
And why are you saying black font diamond?
Because it doesn't look like Fanconi's. Only one parameter is affected. There is MCV is high, and RDW is also increased, and there is aplasia.
Yes.
So I mean that's the age of the patient. Is not like a 60-year-old. So yeah, I would go for black fun diamond.
That's fine. You're very right. This was black font diamond syndrome. I think everybody didn't look at things. He was sent for evaluation of a murmur.
Yeah, which is a sign of anemia, basically. So
So it could be, it could be sign of anemia, but when you say black font diamond syndrome, it could be an underlying cardiac defect as well.
That's right.
Because they usually have got some defect, so there might be a genitourinary defect or might be a cardiac defect. Okay, and the child also seems to be slightly small in size as compared to, so they think there might be some degree of stunting as well, which is common. So this was black font diamond syndrome, because black font diamond, see again we are looking at macrocytic anemia in a child less than 1 year of age. Now at this age, if somebody has got macrocytic anemia, okay, so okay, fine, whether this child has got chronic liver disease or thyroid, which is usually a bit like unusual at this age, okay, tests have also been done. Number two, yes, dietary, well, B12 and folic acid deficiency, especially those who are on goat milks, like if it was of South Asia, children who have, they don't start weaning and they say, okay, breast milk is enough and just child is taking liters of milk, nothing, they can develop B12 and folic acid deficiency. So that can happen in this age group. That can happen in this age group. But this was probably a British child, and he had nothing of that sort in his history. Anyhow, we have done the B12 and folic acid levels as well, normal. So then we are thinking of the genetic things that might, translate into anemias at this young age. So genetic syndrome, either it could be Fanconi anemia, it could be black point diamond anemia, So usually, as I told you, they've got a lot of overlap between one another. But one simple fact that differentiates black von diamond from Fanconi is pancytopenia. Fanconi would, like, if this child had got macrocytic anemia with a low white blood cell count and a low platelet count, we would be thinking of Fanconi anemia. But this is pure red cell aplasia. So pure red cell aplasia usually occurs because of black von diamond syndrome. So this was black von diamond syndrome presenting with macrocytic anemia. Okay, let me tell you another interesting thing that can sometimes spin your mind. Okay, look at this report. What's abnormal with this report?
Is that polycythemia?
Well, I mean, if we just identify the abnormalities in this report, and then from there we can then think, okay, where does this fit into? So starting with hemoglobin.
Yeah, the hemoglobin's high.
Yeah, so hemoglobin is quite high in this, 24.6.
Yeah.
What else is high?
The white cells?
Yeah, white cells are high. What else?
Platelets.
Platelets are normal.
Yeah, platelets are normal. The CRP is...
Yeah, CRP anyhow, that was part of the, don't like focus on CRP. That is like a biochemistry thing. So I mean, still normal, but...
MCH it's both are high.
Yeah, MCH and MCHC is so high, it can't even calculate. But strangely, it's not making any sense. With such a high hemoglobin, the MCV is low. Look at the MCV.
Yeah, it's low.
Doesn't make sense. Like, if you've got such a high hemoglobin, why your MCV would be so low? And then your mean corpuscular hemoglobin is quite high. MCHC is so high that is, like, not even readable. Now, let me tell you one thing. There is only one condition in which you get high MCHC, and that is hereditary spherocytosis. Hereditary spherocytosis. But this can't be hereditary spherocytosis, because hereditary spherocytosis should have low hemoglobin. They are anemic. Here the hemoglobin is 24.6. RBC count seems to be normal. Now this is not making any sense. Like, hemoglobin so high, RBC count is normal, and then MCHC and MCH is both high. Okay, now let me tell you a formula. Now this is, again, you won't find it in other books. Like, I got it from the Manual of Hematology, a trick. So remember this thing, and just remember on your fingertips. Your your RBC count in millions, multiply by 3 is equal to your expected hematocrit. No, sorry, that should be, not hematocrit. That should be equal to your hemoglobin, sorry, not hemoglobin, HB. And HB multiply by 3 should be equal to your hematocrit.
Yeah.
So, his RBC count is how much? 5.
It's normal.
5. So, if I divide 5 multiplied by 3, his expected hemoglobin should be 15. But here it is 24.6. And if I multiply this 15 by 3, that should be 45. So his hematocrit should be what? 45.
Yeah.
Okay. though hematocrit has not been given in this, okay, so for some reason white blood cell count is also quite high, and MCV value is down. It's microcytic, so it's not making any sense.
It could be after splenectomy.
No, what happens basically, I tell you, this is a sort of what is happening, because I told you all these things are done in the machine, that the Coulter, automatic heme analyzer. What happens is that there is some interference pattern going on. Some interference pattern. Something is being picked up as hemoglobin. And because this MCH, MCHC are all formula based, if the hemoglobin is picked as high, everything else would come out to be high. So basically, this happens when you have got lipemic serum. Sorry. Oops. Let me write. Basically, this child had got metabolic syndrome, so he had diabetes and so many other metabolic issues going on. So because of that, his blood had lot of interferences, because there were lipemic serum. There was a lot of sort of fatty substances in his blood, which were actually, when it went to the machine, it was given this wrong calculation. That's why it's not making any sense with a high hemoglobin and a low MCV, which doesn't make any sense. So when the thing was corrected, it came out that the child had got a hemoglobin of only 12, and all the parameters, they came out normal. So lipemic serum, which can sometimes happen in diabetic children and those who have got metabolic syndrome, they can present with this type of a report, which you would be send you scratching your head for hours and hours. That what is this So for this correction, remember your RBC, look at the RBC count, because RBC count would never be affected by lipemic serum. So you always have to look at the RBC count. RBC count times 3 is equal to your hemoglobin, and hemoglobin times 3 would be equal to your hematocrit. Remember this formula. But yes, if this was a frank, let's say anemia, with a high MCHC, there's only one condition in which you have got MCHC quite high, and that is hereditary spherocytosis. Why? Because the RBCs are sphere-like, and usually it leads to hemolytic anemias. Another similar report. Here the doctor has even written kindly recheck. Look at that. Again, an RBC, what you call full blood count report. Look, hemoglobin is 12. Packed cell volume or hematocrit is 21. Okay.
Sorry, Kazmi, I still have the old one on my screen.
Oops, you can't see that?
No, it's an old one.
Okay, let me. I don't know why is it on my one. Just give me a moment. Let me. It might have frozen somewhere. Oh, wait a minute. I think probably somehow the session broke, so it's showing the old one. Let me disconnect and reconnect. Okay, just give me a moment. I will just log off and log in again.
Thank you.
Yeah, just give me a. Okay, can you see it now? Hello guys, can you see it now? Hello, can you see it now?
Yeah. Yes, thank you.
Okay, you're welcome. So, fine. So if you look at this one, this is another report, and the doctor has written kindly recheck because he thinks something is odd with this full blood count report.
Yes, because the HB is normal.
Mm-hmm.
The red blood cell count's only 2.3, and if you multiply that, that should be just about 7
Yes.
for hemoglobin.
Mm-hmm.
Where's the hematocrit? Not on here.
Again, look at the MCH and MCHC. Very high.
Very high, yeah.
Very high. It's very, very high. And he actually, the doctor wrote kindly recheck, and again the blood was, and it came out with almost the same values. So what somebody did was they heated the sample, the blood sample, and did the test again, and everything came out to be normal. So another condition in which you can get this erroneous report where things are not matching up with a very high MCH and MCHC is when you have got what we call as cold agglutinin disease. So cold agglutinins, what happens at normal temperature, normal this. So what happens is that there are agglutinins. So it causes clumping of the what you call this blood cells together. So that gives you very erroneous values. It feels like the cells are very densely packed with very high hemoglobin. Why? Because they are cold agglutinins. So cold agglutinins can occur in like chronic hepatitis C and different types of some chronic viral infections can give you that sort of a condition in which you get cold agglutinins, or some infections like mycoplasma going on over a period of time that can also give you cold agglutinin disease. So basically this child had got cold agglutinin disease, and because of that he was having an erroneous full blood count report. So I gave you these two examples just to tell you that if you get a report which is not making sense, you say, what is this? Look at one value which is not matching with the other value, like one going north, other going south. It's not following any sort of a pattern to it. And I said, you can use this simple one thing, okay? You can use a RBC count, okay, because that is usually not affected by interference, and you just multiply it by 3 to get hemoglobin, and you multiply hemoglobin by 3 to get the pax, or it doesn't mean that it would give you the mathematical same thing, but it would be close to those values. So that can give you an idea. That simply means, and something is way off as compared to that, it means there is some interference. And then you need to tell them that it looks like this sample has got some interference. Please recheck it with special methods, okay? And then they do all these things. They can think of that, and they can either take that thing away, or they can just warm up the sample. So for lipemic, what they do is they centrifuge the thing so that the plasma comes out. They remove the plasma and they put saline in that, and then they rerun the test, okay? And that gives you the normal values. For cold agglutinin, they just have to put in a sort of a warm heme analyzer to give you the appropriate report. So there are ways, like the hematologists and the hematology technicians, they know how to deal with these conditions. But if something is not making sense, just use this formula. That would give you an idea, and then you can tell them that, look, these things are not like adding up. There is something wrong. So can you please look at these samples with special methods, and that would give you an idea what was going wrong. And in some ways, that the method that they applied would also give you an idea that what can be wrong with this particular child. So this was all for today's lecture, which was just focused on looking at the red blood cell issues by looking at the full blood count. Next time we will take some other parameters, like how do we look at thrombocytes, and then we will move on to white blood cells, and then move on to what you call heme oncology parameters. So if you've got any questions now related to this, you can ask me.
So you all these indices, is there any practical significance or use of Menser's index?
Yes. Number one, for Menser index, very good question. Menser index is basically what you have. Do you know what it is? How is it calculated?
It's MCV divided by RBC.
Yeah, MCV divided by RBC in millions. So you have to see whether it is greater than or less than 13.
Yes, that's right.
Okay, that is would be your Menser. So if it is greater than 13, your Menser index is high.
Yeah.
If it is less than 13, you've got what we call as normal or low Menser index. Before you embark on Menser index, remember, number one, it can only be appreciated if the child is mildly anemic. If the hemoglobin level is too low, remember, don't do Menser index. Don't do Menser index, okay? Because Menser index is only applicable. I didn't know this thing unless and until somebody asked the same question, Gupta, that the question that you have asked was asked in the same, that of like, those 9 lectures course. Somebody asked that. And the one of the doctor, I'm forgetting his name, he works in Sir Ganga Ram Hospital in Delhi. He's a pediatric hematologist, very expert person. And he actually explained that he said, like, I know people ask about Menser index, but Menser index, when you are saying that, it's not mentioned in the book. You only interpret it when the anemia is mild. So in other words, if you are dealing with alpha or beta thalassemia traits, then you have to look at the Menser index. Because on one hand, you're looking at your MCV, the other hand, you're looking at the RBC count. So if your Menser index is low, if your Menser index is less than 13, you are probably dealing with thalassemia trait. And if it is greater than, so less than 13 is probably alpha or beta thalassemia trait.
Oh, iron deficiency.
Iron deficiency is more than 13.
Yeah, more than 13.
Yeah, more than 13 would be iron deficiency.
Yeah.
But again, as I said, if somebody is severely anemic, you do not use, even you can calculate the Menser index because MCV value is there, RBC count is there. Never do that because it will give you the wrong grip.
Yeah, okay. All right. Makes sense.
Okay. The other thing also, when you are, let's say, when you suspect, like, let's say if somebody has got low Menser index, you're thinking of thalassemia trait, what would be the next test that you do that to confirm the diagnosis? Yes, HB electrophoresis. Now again, HB electrophoresis should not be done for thalassemia trait. I'm not talking about thalassemia diagnosis or other form, but for thalassemia trait. If you're just like, this question is thalassemia trait, not the thalassemia intermedia or thalassemia major. If you're just thinking of trait, you make sure that the iron deficiency is corrected before you go for HB electrophoresis. Why? I will show you. If I make a graph like this, HB electrophoresis graph. So you have got this F, which is fetal hemoglobin, alpha, which is the adult hemoglobin, and A2. So the A2 has to be more than 3.5 to make a diagnosis of thalassemia trait. 3.5. So if you're too much anemic, this would in any case would be low. So you cannot make a diagnosis. So you have to correct the deficiency first and then do that. But for other, because the adult is not affected, the adult is different one, the fetal is another one. So if you've got full-blown thalassemia, the fetal hemoglobin would be very high. This, in any case, would be very low. But for thalassemia trait, you have to correct iron deficiency first and then order a HB electrophoresis panel. And for Menser index, that is MCV divided by RBC count in millions. So for example, your RBC count is 5.5 into 10 raised to the power 12. You just take the 5.5 and divide by. So if it is greater than 13, okay, you are dealing with iron deficiency. If it is less than 13, you are dealing with thalassemia traits. So that is the significance of Menser index.
Right. Okay, thanks.
You're welcome. Any other question?
No, I'm fine. Thank you, Kazmi.
So I hope you have learned a few things today, how to interpret the full blood count report with the help of interpreting MCV and red cell distribution width, and how to narrow down the diagnosis, and a few like tricky scenarios so that you can think of the what you call the common diseases. So I think if you do practice, because normally we do full blood count for almost any case in which we are investigating for any reason, we do the full blood count. So if we take 5 minutes when we are looking at that and do a little bit of exercise, maybe we can sort of hone on to these skills, and at one point become expert just by looking at that and doing that, and even amaze your fellows by your calculation skills and your your hematology skills.
Absolutely. This really is the basics of indices and anemia, which should be clear.
Okay, guys, no other questions?
No, I'm fine. Thanks once again, Kazmi.
Okay, thank you very much. So if you need the slides or something, just let me know and I will just email it to you guys. And or if you just want to use sort of a stripped down version, just take an image of that, the algorithm, and that would also help you. Just like look at that algorithm and just follow it. Or we can just take a copy of this and attach to our workstations as well in the doctor's office.
Yeah, good idea.
Okay, good.
Thank you, Dr. Kazmi.
Thank you.
Okay, thank you guys. See you later then. Okay. So,
Okay.
okay, all the best.
Cheers.
Take care.
Bye, everyone.
Bye.